Hello, everybody. Thank you for watching this lecture. I'm very honored to be part of the Stereotactic Academy and to be invited by Professor Dr. Patrick Bromstad. Thank you, Patrick. I'm going to talk to you about the anatomy of the thalamus and basal ganglia. Let's dive into it. As Dr. Rotten used to say, I would like to invite you to have the X-ray view and to understand all the structures that we cross until reach the STN and the GPI when we are performing the deep brain stimulation procedure. And before starting to talk about the basal ganglia, I want to ask you to have this coronal cut of the brain as we see in the MRIs, and then we can see the main nuclei. Here we have the head of the caudate nucleus. Laterally here we have the putamen. Medially we have GPI, and then STN, right inferior to the thalamus. That is here in yellow. So first, the striatum. In this inferior view, we have the olfactory tubercle here. So I've removed the portion of the basal part of the frontal lobe and also the temporal lobe here. And we have the olfactory tubercle and also the accumbens, that it's this portion here. And the both together form the basal forebrain. And we have here the accumbens, and then laterally to it, we have substantia nominata. And we have some fibers here, some very thin fibers that are part of the anterior limb of the internal capsule. And posterior to the posterior and superior to the accumbens, we have the anterior commissure. So we have these fibers crossing from one side to the other. And then it's very important to understand that the accumbens is continuing with the head of the caudate nucleus, and the substantia nominata is continuing with the putamen. And here we have the dorsal striatum, that, as I said, the accumbens is continuing with the caudate nucleus. So here we have the caudate nucleus, and here laterally we have the putamen. So it's the dorsal part of the striatum. And the most used target nowadays when we are performing deep brain stimulation, at least, it's the subthalamic nucleus. And here we can see, now I removed more of the fibers of the posterior limb of the internal capsule. And then we have the caudate here, both sides, putamen, both sides, as I mentioned before. Deep there, we have the red nucleus here, and then lateral, anterior, and superior to it, we have the subthalamic nucleus, both sides here. And here in this medial view, we can see important landmarks for us when we are performing stereotactic procedures. We have here the anterior commissure, and posterior here we have the posterior commissure. And then we have the red nucleus here, lateral, anterior, and superior to it, we have the subthalamic nucleus. And here we move the portion of the thalamus, and we are going to discuss more about the thalamus later. And lateral to the subthalamic nucleus, we have some fibers of the posterior limb of the internal capsule. Here in the lateral view, we have some fibers coming up, is the corticospinal tract. And we also have some fibers coming up here that are fibers of the medial lemniscus. And once I removed the fibers of the corticospinal tract, we have the subthalamic nucleus here. And you can also see important landmarks here, the optic tract, and also GPI, GP, again, the anterior commissure, and the substantia nominata here, continuing with the putamen, as I mentioned before. So here we have the continuity, and it's not very precise where we can it stops being the substantia nominata and when it starts the putamen. Usually we think about a line here at the level of the anterior commissure, and when it's below it, we think that we say that it's the substantia nominata, and it's what it's above it, we say that it's the putamen. Well, in this zoom view, we can even see some connections of the STN, and here again, red nucleus and the STN, and we have some fibers connecting the STN to the mammillary body. And remember, mammillary body, it's related to memory. And then we have some fibers here connecting to the hypothalamus. And also even some fibers coming up here connecting to the olfactory tubercle. And this might be a reason why we have some changes when we are stimulating the STN in the olfaction. So probably some of my patients already mentioned that. And also we can have some patients referring dizziness when we are stimulating anterior there in the STN, and even some cognition problems when we are too anterior in the STN. So it might be related to these connections. So I got to show all these 11 connections, and you can see here the beautiful drawing in all the views. And you can, if you point your phone to this QR code, you can see and read this paper. And I got to show connections to the caudate nucleus, medial frontal cortex, the PPN, the pedunculum pontine nucleus, and also the substantia nominata, GPE, GPI, substantia nigra, olfactory tubercle, as I showed before, hypothalamus, mammillary body, and putamen. So let's have that X-ray view, as I mentioned, and let's dive deep and understand each structures that we cross when we are reaching the STN. First, we have the superior frontal gyrus, and then once we move deeper, we get to some of the U fibers, and then some fibers of the superior longitudinal fasciculus that I've removed here, some fibers of the corona radiata, and when we cross those fibers, we reach the thalamus, and then right inferior to it, we have the zona incerta, and then the STN. And usually we get to the portion of the STN between the associative and the motor portion of the STN, and more in the more lateral portion of the STN. Even when we are trying to reach the tremor area that it's connected, the area that we need to control the tremor, and also the bradykinesia, and also the rigidity that the patient might have. So this is usually the area that we aim to, and I'm also going to talk about that later on. And then we have in this anterior, superior, and lateral view, we have the red nucleus, and here lateral, superior, and anterior to it, we have the STN. Lateral to it, we have the posterior limb of the internal capsule. We can also see here the GPI, GPE, and then putamen. And here we have some fibers of the anterior limb of the internal capsule. And then anterior medial, we have a portion of the head of the caudate nucleus that it's deep there. It's going to be when we are inferior to the anterior commissure, which here we have the accumbens. So, and then this is a paper that shows these symptom-specific networks in Parkinson's disease, and you can understand better the deep connections and also the idea that we have here, that is not the first time that it's shown, but it's very interesting to see that we have some fibers that are connected to tremor, that are these green fibers, some fibers that are connected to the control of axial symptoms, and some fibers connected to the control of bradykinesia, rigidity. And based on the symptoms that the patient have, we might get a specific area in the STN to control these symptoms. Okay, and then I highly recommend you to see the atlas, that you can see many of the connections that I mentioned here. You can see these connections showed here, that I've shown here in the atlas, together with many connections also dissected back to Georgios Skandalakis, and I worked together with Dr. Andreas Horn and this team, and Nandita Rajamani and Helen Friedrich, to have this beautiful paper that you can understand better this neuroanatomy. So moving to the GPI, that's the target that it's used the most, I would say, and one of the most used when we are thinking about lesions. And it came from the pallidotomies, and we are using a lot to treat patients with Parkinson's disease, and also even Tourette's or dystonia, of course, is the most used target nowadays to treat dystonia patients. And let's understand a little bit more about its anatomy. So in this anterior view, we have here the optic tract here, both sides. In right superior to the optic tract, I removed the portion here of the fibers of the frontal lobe and also the temporal lobe, and then you get the substantia nominata again and accumbens again in this view. And then you have some fibers of the anterior limb of the internal capsule here. And then right superior to the optic tract, we have the GPI here. And we have some fibers here of the anterior commissure coming from one side to the other. Okay, and then we also have you also can see here the STN, both sides, mammillary bodies here, both sides, and here the rad nucleus, inferior, medial, and posterior to the STN. And here in this lateral view, we have the optic tract. We have mammillary bodies here, and here we have the STN. And right superior to the optic tract, we have the GPI. And it's an important landmark for us when we are doing the microelectro recording when we are doing the macro stimulation. So, and we are targeting the inferior portion of the GPI. The patients might even mention that they are seeing some light during the procedure when we are simulating. So this is something that might guide us when we are doing this procedure. So in this inferior and anterior view, we can see the GPI here, both sides. Here we have a mammillary body and the fornix coming up here. We have STN both sides, and here the rad nucleus both sides. And we also have GPE, and then continue with the putamen, and then medially we have the continuing the substantia nominata, and then medial to it we have the accumbens here, both sides. And it's very important to really see these structures and to have a direct target of the GPI. And then we have a very good image that is the F-gator, that it was developed by the team there at University of Florida. And then we have, it was this paper, and that you can see here in this QR code. And then you can really see the boundaries between the GPI and the GPE. And even we have the lamina there inside the GPI, that it might guide us where to exactly put our lead to improve the more symptoms in Parkinson's disease. So, and it might guide us to really have a good result in the surgery, comparing to not seeing the structure and just using those magical numbers, the stereotypic numbers, without seeing the structure. So this is very important and very helpful when you're targeting the GPI. And here you have not only the GPI, SDN also, and also the thalamus, and I'm going to show you some sequences that might help you with that. So with the GPI, I've got to dissect all these connections. We have the thalamus, substantia nigra, PPN, GP, SCN, amygdala, and putamen. And you have all these connections here that you can see in this QR code. And this is the paper, and I highly recommend you to see the supplementary data that I spoke about many of these connections that I'm mentioning, and which side effects and which improvement you might have when you're treating your patients. So this is very important, not only for neurosurgeons, but for those of you that are watching here. It's nice to also share this lecture with your neurologist, the neurologist that is working with you doing your programming, because it's very important to understand all these boundaries and all these connections when we are doing when you are performing the programming for the DBS lead. So moving to the thalamus, that is a very important nucleus to treat essential tremor when we are targeting the VIM and also the posterior portion of VO. There are a lot of research in the centromedian nucleus to treat epilepsy. It's a very important nucleus. And also when we are targeting the anterior nucleus, we might help a lot of patients also with epilepsy. And also there are some studies when we are targeting the centromedian parafascicular nucleus, we might help patients with Tourette syndrome. So these are very important nucleus with a lot of things and a lot of details to understand. And here in this anterior view, we have the red nucleus here, both sides. We have STN, like superior to it, we have the zona incerta. And then here in yellow, we have a portion of the VIM, and anterior to it, VO. And then medial, we have the centromedian parafascicular nucleus here, both sides. In this medial view, we have the dentate here inside of the cerebellum, and we have these fibers coming up here, getting to the red nucleus. And we also have these fibers coming up, that is a portion of the medial lemniscus, getting to the VP or VC, the nucleus of the thalamus related to the sensory, to the sensation. So it's something that I usually use. I'm usually getting the anterior border of the VC, and then I'm moving the lead. I'm putting the final lead 4 millimeters anterior to it to get in the border of the VIM and VO. And also here in this area, like posterior, inferior, and lateral to the red nucleus, we have the PPN, the pedunculopontine nucleus. And here we have the anterior nucleus, so that's connected to the mammillary body. It's connected to the mammillothalamic tract. Here in this anterior view, we have the dentate, both sides. We have these fibers coming up here. That is the dentate to huberothalamic tract, and we have these fibers coming to the red nucleus, and then we have the fibers coming up here after to the VIM, and we also have the VOP, and VOA here. You have these fibers, and we also have about 25% of these fibers coming to the posterior portion of the VIM. But usually the area that we are targeting is the anterior portion of the VIM and also the posterior portion of the VO, and that's where we get the fibers of the dentate huberothalamic tract reaching the thalamus. And here in this lateral view, we have again the fibers of the mammillothalamic tract. Here we have the mammillary body. We have the mammillothalamic tract coming up here, and we get into the anterior nucleus of the thalamus. And this is an important nucleus. It's the most used target to treat epilepsy.
nowadays. But we also have some fibers here coming up to some fibers of the medial lemniscus coming up here to the VP, and medial to it, we have the central median parafascicular nucleus, that you can have an idea in this view, the connection of the mammillary body with the anterior nucleus. And we also have, can you see here, these are fibers of the posterior commissure coming up here and getting to the CM, PF, the central median parafascicular nucleus, that have fibers coming anteriorly here, reaching the cingulum, reaching the frontal lobe, and also going posteriorly and getting and reaching the occipital lobe. So we, like, the CM has a lot of connections with many areas of the brain, and it's also an important target when we are treating epilepsy that are coming from many areas of the brain, like frontal and even temporal or occipital. So here, when I mentioned about the really seeing the structure, it's very important. And with this new sequence that was developed by Dr. Harv Akron there at Queen Square with this great team, he got to show exactly where it is the VAM and also the VP and also the VO. And you can see the comparison with the dissections that I just showed you. And this is very helpful to really position your lead exactly where you need, not only for deep brain stimulation, but also when you're performing focus ultrasound procedure or a lesion procedure with radio frequency. You really need to see the structure. You really need to see where you are doing the lesion to avoid complications, to avoid problems to the patients. So and also with the QR code, you can get to read more and to understand more about this new sequence. That's the FAT one. So with that, we can help our patients to improve even tremor, rigidity, and bradykinesia even during surgery. And for dystonia, when we reach the GPI, we can help them to improve all the contractions that they have with the dystonia. This was 3 months after surgery. And even we can combine targets. So for this patient, she had a writer's cramp, and we went anterior to the VIM to improve her tremor because she also had tremor. She's a physical therapist. And you can even follow so this is a F-Gator sequence, and comparing with the neuroanatomy, you can see here, you can even see the CM following the posterior commissure, and then lateral to it, we have the VC or VP. Anterior to it, we have VIM, and then anterior to it, you have VO. And the area that we position the lead is right anterior to the VIM, as you can see here. So, and then we got to stimulate the GPI and the VIM, and she improved the symptoms of the writer's cramp and also the tremor. And the most used is for the anterior portion of the VIM and the VO, and also getting the sweet spot of the dentator-huberothalamic tract. It's to treat essential tremor that is life-changing. This patient would not leave his home to go to weddings or to reunite with his family members, and he could go back to that. He could even hold his grandchild after the surgery. And then I want to thank all my mentors, mainly Dr. Rotten, who was the best mentor I've ever had. He was always going to the lab and asking us to keep working. And even the last words for us during when before he passed was keep working hard. And I think that's the reason why I'm here. I'm very pro education, and I was very happy when Dr. Patrick Bronstad invited me to share this. It's something that I could spend many hours talking to you about neuroanatomy. I try to give you a broad view about this subject, and I highly recommend you to go deeper in the papers that I mentioned. And I'll be more than happy to answer any questions that you might have. I also want to thank Dr. Kelly Food, Dr. José Osvaldo, my mentor in the University of Florida, my mentor in Brazil, here in Brazil, my team here in Brazil, and also the teams I've been collaborating with at Mayo Clinic, at Austria, and also at Harvard in Boston, and also at Queen's Square. So I thank you very much. And here's my mail and my social media if you want to reach and talk and discuss more about any of these anatomy subjects. And also, it's always great for me to hear questions, because it's kind of ignition for me and fuel for me to go back to the lab and to perform more dissections and to keep working, as Dr. Otton used to say. Thank you so much. I hope you enjoyed, and I'll be more than happy to answer any questions if you have. Bye-bye.